Friends, good evening. At the outset, let me welcome to this extraordinary event of joint collaboration between Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India and India Medtronics Private Limited. Keeping in mind the newer techniques and technological development which are happening and going to be adopted by all of us in near future. In skill development courses, modules are designed to enhance the operative and endovascular skill in practicing cardiovascular surgeons. We have designed 8 modules which are minimally invasive mitral valve surgery, which is going to be today. Then minimally invasive aortic valve surgery, which is going to be taken up on 13th of February. Then minimally invasive coronary artery surgery on 13th of March. Surgery for thoracic aorta on 27th March. Surgical treatment for heart failure on 10th April. Management of cardiac arrhythmias on 24th April. Transcatheter aortic and mitral valve replacement on 8th of May. And the last one is endovascular stenting of thoracic and abdominal aorta, which is going to be happening on 22nd May. The course has been nominated as the best by international and national cardiovascular experts. We look forward to welcome you to a lifetime experience of unparalleled feast of knowledge sharing and skill development. Today, we have 2 of the guests which are going to address this very cause of joint effort of Smith SI and Medtronic India. The first 1 hour, we are going to be with Payman Sardarinia, who is a senior consultant cardiothoracic surgeon in the Department of Cardiothoracic Surgery at the Maastricht University Medical Center, the Netherlands, where he specialized in minimally invasive cardiothoracic surgery. He is also the lead and instigator of mitral valve program in Maastricht. Dr. Sardarinia earned his MD and his PhD from the University of Antwerp, Belgium, and underwent residency training in general surgery in the same city. Dr. Sardarinia was awarded the Pfizer Educational Prize in 2009. This prize is bestowed by the University of Antwerp on one young specialist for excellence in clinical, scientific, and surgical qualities during his or her whole residency across all the surgical specialties. Following his residency in the general surgery, Dr. Sardarinia underwent a fellowship training in cardiothoracic surgery at St. Antonius Hospital in New Vision, the Netherlands. He is board certified in general and cardiothoracic surgery in Belgium and in Netherlands. Dr. Sardarinia PhD research focused on prognostic factor of lung metastasis and non-small cell lung cancers, particularly how tumor growth pattern can inform post-surgical outcome. He has received multiple awards for his research, notably the American Association of Cancer Research Scholarship in Training Award and European Association for Cardiothoracic Surgery Young Investigator Award. Dr. Sardarinia is an all-round cardiothoracic surgeon with special interest in the surgery for mitral, lung cancer, and minimally invasive adult cardiac surgery, especially endoscopic mitral valve repair, beating heart, mitral valve repair, and wide lobectomy. Over 90% of his procedures are done fully endoscopically with 3D vision. The focus of his academic and clinical activities is small tailor-made surgery in which one select plan and performs interventions with mathematical precision with the use of new technology. He is an inventor and pioneer in surgical simulation, 3D printing, and training of endoscopic mitral valve repair. He received the EACTS Techno College Innovation Award for his invention of high fidelity endoscopic mitral valve surgery simulator in 2014. In addition to introducing the innovative minimally invasive approach at his home institution, he is the founder and director of EACTS course in minimally invasive techniques for adult cardiac surgery and endoscopic mitral valve repair. He has been the program director of over 50 courses in minimally invasive cardiothoracic surgery, especially for mitral, and has trained more than 300 surgeons from all over the world. He has given over 100 invited lectures worldwide and helped many centers starting the minimally invasive programs. He is regularly consulted for complex mitral patients and operates patients referred to him also from other countries. He has been an EACTS counselor and a member of various EACTS committees since 2008. He is an associate editor of European Journal of Cardiothoracic Surgery and an active member of the major cardiothoracic societies like EACTS, ATS, and STS. He was recently appointed as editor-in-chief of ICVTS and will assume this position from already assumed this position. With this introduction, let me invite our very Dr. Payman Sardarinia to talk about basically his vision, how to upgrade and enthuse techniques and whatever innovation he has developed in the area of minimally invasive mitral valve repair and replacement. Over to Dr. Sardarinia.
Thank you so much for the kind introduction. I'm very humbled and also pleased that I have the opportunity to present here. Let me share my screen. I don't know. So, do you see my slides? You see my slides?
Yes, we can.
Okay. So basically, what I'm going to talk about, I'm going to talk about not only how we operate endoscopic mitral repair in Maastricht, but I just want to more focus on to give you a formula of success that if you start with that formula, probably it's going to be more successful in the careers, especially in the careers of surgeons who are starting with the program. These are my disclosures. The content of my talk. So first I want to elaborate on the new care philosophy for mitral valve pathology, and I will talk about why we need a new care philosophy. Then I want to talk about the reorganization of this of the patient care, which is basically based on this new care philosophy. I will talk about smart surgery concept. Then I have a part regarding endoscopic mitral valve surgery. So we go into details, different aspects of this kind of procedure. I will talk about how to get trained for endoscopic mitral valve surgery, especially because I have founded and invented a simulation, a program for that, and I've trained many surgeons worldwide. So that would be maybe beneficial. And then at the end, I will give a specific recommendation for starting surgeons. So why do we need a new philosophy? This is a study published in Annals of Thoracic Surgery. I think probably you know this, and subsequently has been published in a different format. And this is a depiction of all mitral valve surgeries done in the United States. Here you have the proportion of repair, and this is a number of cases, and every dot is a surgeon. So what you see here is that there is a direct association with the number of operations you do and the repair rate for mitral. It doesn't mean that if you are a low volume surgeon, like here, you're doing a bad job. No, you see low volume surgeons can have also a high repair rate. But it is not about individual surgeons, and that is also my point. If I talk about things today, it is more about from perspective of the patient and perspective of the field. So if you look at this graph, what you see is if you are a low volume surgeon, for the community, there is no reproducibility. So as you know, science is all about reproducibility, and art, it is about exceptionality. And this is the core issue what we have in mitral valve surgery. And you have to remember that the mitral valve surgery is also very heterogeneous pathology. So it is not about one procedure. So if you zoom in, this kind of heterogeneity and not reproducibility of the results are more pronounced. Actually, the same thing is true for even transcatheter mitral valve operations. This is a study published in JACC in 2019 in a huge number of patients, and you see that increasing institution experience is associated with improvement in procedural success, time, and complications for MitraClip. If you go even further, even experience in echocardiography is very important for mitral. So here you had 5 novice, 3 intermediate, and 2 expert assess 50 valves, and you see a difference between all of these people assessing the mitral valve. And as you know, echo is the eye for a surgeon, preoperatively, intraoperatively, and postoperatively. So what is the problem what we have in the field? And is that we don't even are able to reproduce the same procedure in the same patient. You have many successful programs that are built around successful individuals. And we surgeons, we want to be unique. We want to do unique things. We want to do things that nobody else can do. But science is about reproducibility. Science is about successful formula. And science is it's not about craftsmanship. And my talk is mostly focused on how we can get there from craftsmanship to smart surgery. And why is that needed? Because it is not that you can do the great job for your patient in your region, in your community, but how can we have a formula of success that is reproducible in the hands of as many surgeons possible and in many patients possible? So consider the following, that more than 70 different devices are being developed for mitral valve pathology. 70 devices. And one crucial thing is that probably none of these devices will be suitable for all the pathologies. So you cannot use them in all the pathologies, one. Nobody is going to have expertise in all of them. Suppose that even 5 or 6 of them reach clinical practice. And that's why it is important, one of the important things is that we need to work together if you want to help patients with mitral valve pathology. So let's look from the patient's perspective. What patients want? Of course, survive the procedures as regard to mortality and complications. They want to get the intended treatment. If you say mitral repair, that they get a mitral repair. They want that we do the procedures less invasive as possible, they want to be better off afterwards with regard to the symptom relief and quality of life, and they want predictability and durability. What do patients get? And that's also important. If you look at mortality and complications, it's really dependent where you land. This is 2 studies published in New England Journal of Medicine that is across all the surgical specialties, including cardiac surgery. You see there is a direct association between volume outcome of the hospital and volume outcome surgeons. And I showed you for the mitral, the SDS data. Even if you look at the mitral repair, and I showed you generally around 41 to 60%, depending of whether it's functional or degenerative. So it is like tossing a coin. What about patients? What do they get with regard to the minimal invasive? This is a study published in 2018, also based on a STS database, and you see 23% of patients, only 23 get a less invasive procedure. And if you talk about less invasive procedure, is everything from thoracotomy, direct vision, endoscopy, robotic. What about symptom relief and quality of life, which is very important, is only incidental reporting. We surgeons tend to look only to our operative results, whether the patient gets home and survive the operation. What about the predictability is really rested in the hands of the surgeon. You never say to a patient, I will give you 100% guarantee that I'm going to help you. You always say, we will see during the operation. Obviously, even in science, you talk in the terms of probability, but in many cases, what surgeons do, they say, we see it during the operation because they have no particular pathway that gives that predictability. What about durability? This is also published in JACC, as all the patients in New York State. And what you see, this is actually cumulative incidence of mitral valve reoperation within 1 year. And there is quite a difference between whether you do less than 25 or more than 25 operations per year. Also very important is that we have to be mindful with regard to the mitral valve results in patients older than 70 years. Of course, in young patients, the mortality is very low, but once the patient gets older, the mortality increases, and you see the mortality up to 20% if you are older than 80 years old. And if you look at the 1 year mortality of patients above 75 is 14 to 16, depending whether they get a repair or replacement. And this data come from all the major prominent surgeon centers in Europe or in US. So if you want to have exceptional patient care, what we need is we need adequate training, because obviously you cannot, with regard to the mitral, if you look the median number of mitral valve surgeries per surgeon per year in the United States is 5. In Europe is around 10. So, and if you consider that you need more than 150 operations to overcome your learning curve for mitral valve surgery endoscopically, then you need a different kind of training. And I like to say we have to get our surgeons trained like air pilots trained to fly airplanes. We need centralization and subspecialization. I always say you can be good at many things. You can be excellent in couple of things, but if you want to provide exceptional care, and this is from the philosophy of those who work in academic conditions or academic centers, then you have to have a focus, and you have to focus on a pathology, not a procedure. If you focus on procedure, you have to be mindful that scientific and technological advances are surpassed by time. So you will lose your practice if you only focus, I'm a minimal invasive mitral surgeon. No, you have to be a mitral expert on the pathology. You shouldn't focus on the procedure and the concept of a smart surgery. So for all of this, you need some reorganization of care. This is a concept of personalized medicine we introduced, published in 2017, and that is actually how we have organized the program, how I built the program in Maastricht. And this is built on 3 pillars. One is, if you want to have exceptional patient care, you should focus on the whole process of care and not only the treatment, not only the operation or intervention. The other thing is you need to work with dedicated teams throughout the process, from preoperative phase to postoperative phase. And as I showed you, for mitral valve pathology, your imager, the volume and outcome as the dedication of the image is also important. The volume and outcome of interventional cardiology is also important. It is about bringing a team together, taking care of the heterogeneous pathology of mitral valve. And why is that? I always say it is like, I have never seen somebody washing a rented car. Why is that? Because of ownership. As a surgeon, you have an ownership about your patient. If you want to have exceptional patient care, what you need to do, you need to create a team that have the same ownership regarding the program. And that is if you work together, this dedicated team for the heart team, operation, and so on. The third thing is you have to consider in this concept 2 questions. Whether which technique is the best technique for which patients, and the other thing, whether the patient will benefit from the procedure. For example, if you have an 85-year-old male coming for the mitral valve pathology and in good clinical condition, and you say, yeah, we can operate this patient, yeah, but it is not about technical feasibility or whether the patient will survive the operation, but the question is whether the patient will also benefit from the operation. Maybe that patient will benefit more from transcatheter technique. You cannot make those decisions without a functioning heart team. And the last pillar is preoperative planning, which using actually technology that you have nowadays to select, plan, and execute operations. This is a Maastricht policy of heart team. Every patient is discussing a heart team, even one single vessel disease. And even this is not ideal. At some point, I created a dedicated mitral heart team. And as I told you, with the question, will the patient benefit and is a patient suitable for technique? And that is actually how we build the program. And this is a study is in publication. Over thousands of patients discussed or treated by general heart team and dedicated heart team. You know, the heart team concept is a class 1 recommendation in European and US guidelines, but there is no evidence for that. There is no data. And this is the first data we have, and there is significant difference in survival, on the long-term survival between patients treated by general heart team, dedicated heart team, and these patients didn't follow the advice of the heart team. So patients treated by the dedicated heart team had 61% lower adjusted relative risk of mortality at any time point. And it is adjusted for more than 17 different confining factors. So What about the smart surgery? Nowadays, you have technology that you can go through the anatomy of the patients layer by layer. When I was in training, I used to scrub with my supervisor, and he, during the scrubbing, he always asked me, "Have you done the operation already in your head?" So that was a kind of preoperative planning. But nowadays, you have technology. You can go layer by layer through the anatomy of the patient, and you can plan your operation. This is a technology that I use now more than 7 years. You can upload any imaging modality. You get a 3D hologram of the anatomy of the patient, and you can go through it. And we published a study in 2016, and we evaluated patients referred for mini aortic valve and mitral, and we found that 30% were anatomically less suitable, or they had anatomic variations that you had to consider during the operation. It doesn't mean that you cannot do those procedures, but it means if you know that what is the problem, you can adjust your technique, or you can, for starting surgeons, you would say, don't do those operations in the beginning. You can even go so far with new technology that you can even simulate your cannulation or many parts of the operation. Here you are simulating because of tortuosity of the iliac vessel. Here you have simulation of the size of the cannula that you use. You know, in an academic setting, I have the availability of those technologies, and as an academic surgeons, my task is also to find new way of doing things. So before going to the OR the day before, my perfusionist knows which groin, which size of cannula. There's no surprise. You can even go further. This is a 3D TOE of a mitral valve, a P2 prolapse. This is a new imaging modality of Philips machine. And here you can have a computer model of this mitral valve, and you can stop it at any phase of cardiac cycle. You can capture what is the what is the pathology. And we have actually created a process that you can, based on the TOE, process any mitral pathology. You can print it. Of course, nowadays you only able to print it in the hard material, but we have created a process that you can build a negative mole of the pathology, and you can cast a special silicone, a material that we have developed, and you can put it in the simulation and simulate the operation. So any pathology we can print, any pathology we can reproduce the silicone replica of the valve, and we can put it in a simulation. This is another publication that we've done. As you know, the transapical beating heart mitral repair with the NeoCord system. As a way of planning, we did this kind of printing in all our patients at the start of the program, as extra modality to see whether these patients are suitable or not. This is a simulation that I have developed, and this is here at the P2 prolapse in a simulation. This is the day after in operation. This is another patient. These are prospective patients that you can print the valve of the patient, put it in a simulation, and repair it. This is not that you need to do this in every patient, but I want to that you appreciate the concept. The concept is that in the future, you don't need to print it even. You have a computer model and you choose which technique is the best for this heart, for this pathology. So then we enter the part of endoscopic mitral valve repair. You are all familiar with minimally invasive mitral valve repair. I really dislike that terminology, minimal invasive, because nothing we do as surgeons is really minimal invasive. At best it is minimal access. But if you say minimal invasive, it is also not really clear what you mean by that. Some people would say anything but full sternotomy, so mini sternotomy as a minimal invasive. Some would say it is about the length of incision, about rib retractor, endoscope, robot, so nobody knows. That's why I also use the terminology endoscopic, because it's designate what I do, how I do an operation through an endoscopic approach, and doesn't qualify in a positive or negative way what I'm doing. So what are the available minimal invasive techniques? It goes from mini sternotomy to fully VATS endoscopic. I think that is the least invasive all of them. And I will elaborate why I think that. This is the most prevalent technique. It's actually a technique from Leipzig. You have a lateral mini thoracotomy. As you know, in this kind of technique, you do the operation with direct vision, and because you have to be in alignment of the mitral, the thoracotomy is lower, more lateral. But because the spaces between the rib become smaller at the lateral size, that's why you need a retractor, otherwise you cannot see anything. And the light, this is a camera giving light, but I mean the operation is done through the direct vision. This is an endoscopic assisted 2D, which was developed more in Aalst in Belgium. The mini thoracotomy of the port access more anterior, and you know spaces between the rib anteriorly are the larger, and that's why you don't need a rib retractor. And the other thing is, because you use endoscope, you don't need a rib retraction. And the other thing is, the camera is in the same intercostal space below where you normally do the mini thoracotomy for direct vision. Why? Because the endoscope is your eyes, and you don't look through the incision, but the endoscope captures the incision. This is the robotic assistant. So you have the same port access incision. It can be larger, smaller, bigger, but this is the most common way. And you have 1, 2, 3, 4 ports. You have chitwood, and some can use also interglued. But this is the most prevalent way of doing a robotic assisted mitral repair, and it is the way I do it. So with 3D camera, that's why you see it is dark. Is a 10mm camera. This is the utilization incision, and most of the time I use interglued, and in some cases I use chitwood, and in other cases I use fibrillating heart, depending on the anatomy of the patient. So what are the indication and contraindications? In principle, you can repair and approach every valve endoscopically, and is really primarily dependent on expertise and experience of the surgeon and the center. But there are some relative contraindications. Obviously, if you cannot enter the chest and expose the heart safely because of the previous thoracotomy, pulmonary resection, and pleural adhesions, deformity of the thorax, if you cannot do a safe peripheral cannulation, extensive peripheral vascular disease. But for all of this, there is a solution. If you are thoracic surgeons as you can clear the lung. If you use a subclavian cannulation, you still can do it. But I would say these are the contraindications for starting surgeons. The other thing is, of course, if you have a disease of the aorta, if you cannot safely clamp the aorta, if you cannot safely give cardioplegia, so if you have a grade 2 or more aortic regurgitation. And these are relative contraindication. I would say don't start in the beginning. If you have a short females, obese, they are very small chest, high diaphragm, it's very horrible to do those cases. Heavy calcification of mitral annulus, if you have to do something about calcification because your instruments are not adequate to address that. Giant postures, So you have somebody more than 2 meters, 150 kilogram, and you have with the Barlow disease, you have to cannulate right, left groin, and then also the neck and all those things to be able to do the operation. Then I would say do stenotomy. And if you have endocarditis, whereby you are not sure that about the aortic involvement. So the question, is it safe to perform with regard to the mortality? Is it safe to with regard to the complications? And is it effective with regard to the short and long-term results? These are all the meta-analyses published in the literature, and all these meta-analyses say there is no difference between minimal invasive mitral valve surgery and stenotomy. There are some complications that are more prevalent in minimal invasive, but in essential, in comparative studies, there's no difference. There are many single center surgeon studies where you see excellent results, but this comes back to the centralization, subspecialization, volume, and outcome, as I indicated before. There's only one study showing differences, and that is for redo operation, that is by my group, and pool analysis. We showed that the minimal invasive mitral valve surgery, in those patients, you had reduced mortality, reduced length of hospital stays, reduced rate of reoperation for bleeding, and similar incidence of stroke. So in a sense, for reoperative mitral valve surgery, it is more, the patient will benefit more. This is how I position the patient. I mark everything, the position of diaphragm, the position of everything. This is incision for endoscopic. If you do direct vision, the incision is lower. This is how is when the patient is draped. I'm going to, because of the time, so you open the pericardium, you do 3 stitches on the pericardium, one at the aorta, one at the level of atrium, and the other one at the level of diaphragm. And the next step is actually this is the most important stitch and most difficult stitch. Be mindful only taking adventitia and so on. You do a needle. What is also important, you put a stitch at the interatrial groove, and you open the interatrial groove. And to open it, you have to go below the fat, and then you have a very clean, clean dissection like here. So then is placement of the chitwood. If you place the chitwood, it is important that you look at the left appendix. You push it with the sucker down so that you can not damage it. Then you come at the level of the mitral. You, of course, based on the echo, here is a commercial prolapse. You identify the pathology, and what I have is actually a ruler that I put to get exposure of the subvalvular apparatus, and you see is a great view. It's actually a picture of the life surgery I've done during the EX course some years ago, and then you put cords here, normally cords in the papillary muscles, and you have to respect. It is the posterior papillary muscles of posterior leaflet. You go posterior. This is intermediate head, and it is anterior. So you have to respect the nature if you repair the mitral. And then at the end is you put a ring, and you measure the during the water test and ink test. Of course, most of the time you use a respect technique in endoscopic. Sometimes, as you see here, is a half Barlow disease. You have to resect something because you cannot put anything in one corner. So here you have to do some sort of resection to create a mitral valve here, and then you do the anterior leaflet. How you suture it, this is published in MMTCTS. It is freely available. I developed a map for endoscopic suturing using the simulation and using the patient. That can be helpful for people who want to start. Normally, this is you start in endoscopic here, backhand. This is reverse backhand, and this part you do at last, because otherwise you have some sutures like trees in your vision. As I told you, I use a ruler and I use that to expose the subvalvular apparatus. You can do any pathology with endoscopic. I just want to show you, maybe that's all. This is the B-leaflet prolapse. This is endocarditis, B-leaflet endocarditis. So you cut actually all the infected tissue. Then we will patch it. So, and then I will show you, this is a repair to somebody with the mitral, and then at the end you can even repair this kind of wall. So what about the training? An expert is a person who has made all the mistakes which can be made in narrow field. I think everybody would recognize this. And the question is whether that should be true for mitral valve pathology. This is the traditional learning curve for anything. And there are so many established evidence that if you incorporate some sort of simulation, you can reduce the steep learning curve. And this is a publication by Leipzig Group, which you see that you need 75 to 125 cases to overcome your learning curve. And you need to do 2 of these operations per week to do that. It is a simulation that we developed. You can use it for training, education, preoperative planning, as I showed you, and also predictability. And since 2014, we had the endoscopic port access mitral valve repair program. Unfortunately, because of the COVID, last year we couldn't organize it. And we have already trained more than 300 surgeons in it. It's a 2-day course. The idea is like air pilot training course. You get training and theoretical aspect, in technical aspect. Around 90% of the participants were senior surgeons, and we published the result of the first batch of the surgeons. And it was interesting. If you consider that the time that surgeons had during two days to spend on a simulation, that was per surgeon only 4 hours. And you see in the 4 hours, you had surgeons beginning, they couldn't do anything, and then all of them improved. All of them improved with regard to the time, but also with regard to the accuracy of what they did. And 33% of the participants started with a minimal invasive mitral valve surgery program. And those who didn't start it because of lack of support, lack of volume, lack of facility. So we did a follow-up after years. So you would say 33% is not so good, but at the end, this was only one program, one point in the time. So this was not a full program that you assist them. And the simulation-based training is also not only to teach people, but also make them conscious about what you need to start the program. So those who didn't start the program, they saved their career, their patients, because they had not the right conditions. So that is also a good outcome of simulation-based training. This is a new simulation that I have developed with my team. This is actually, the previous simulation was only for one operation. This is a torso that is prepared for any approach, mini sternotomy, sternotomy, from light, from rate. And what we are going to do, because this is like a flight case, you can take it everywhere. We are making different modules for different operations. So you take this module, this is for mitral, for beating heart, for coronary vascularization, for aortic valve. So you have a platform that you can use to teach many operations. And the other thing is, the future perspective is, we had only one course, but the idea is you have a program from start to end. You assist colleagues. They come to the course, they get a simulation at their institute, they get proctoring and mentorship from the program. So this is the final part of my talk, and that these are 10 recommendations. There are not 10 commands. It is published in 2019 in Journal of Visual Surgery. It is also available. If you want to start a program, you need to work in a team. And you have to understand, most of you work in associations, so you have to have support and understanding of your colleagues. If you have 5 surgeons working together and everybody wants to do mitral, it doesn't work like that. You have to have a support from your cardiologists, and you have to team up with them, because at the end, they refer the patients and they will see the patients for many years to come. So, so as I told you before, you have to create ownership among your team members. Volume and outcome, I have already indicated that is very important. It doesn't mean if you work in an institute, you do only 25 mitrals in a year, it doesn't, you shouldn't start. No, it is all about the potential of your institute. If you are working in an institute and around that institute, you have 10 other institutes all doing minimal invasive mitral, of course, if you want to start, it's going to be difficult. But if you are starting in a region that they don't have the program, you have more chance of success. As I told you, heart team approach is a patient-centered approach, because you bring different experts with different perspectives together. They have a different platform to treat patient, and you have to always see technology procedures as a tool in a toolbox, and you have to ask yourself, is the patient suitable for the technique? One, and is the patient going to benefit from that technique? I told you skills development is a long process, but you have now technology to train yourself on a simulation. Even if you cannot have a simulation advanced as mine, you can still make your own very low fidelity. Some skills you shouldn't develop in patients. Mentorship instead of proctorship. Unfortunately, endoscopic mitral valve surgery is a complex process, different layers. And companies provide proctorship for their product. So you have to license with an expert, comfortable for you, have to observe the platform he's working with and use him as a mentor. Then operative planning, as I told you before, is very important. It's a half of the job, because you can prevent many disasters by doing operative planning. I would say for this kind of surgery, a CT scan is minimal that you can do. Copy paste in the beginning, and maybe that is the most important point that I can, because if you are more advanced and experienced, it is difficult to forego what you're used to do. And what is very interesting, if I explain to a surgeon about a procedure, the first thing that they ask, can you do it differently? So they are continuously trying to process, yeah, maybe it's a better way to do, but you have to understand that the platform that you are using is based on many pitfalls they had. So don't just copy paste, and then once you are advanced, you can adjust your technique. So don't do trial and error based on wrong assumption. Remember, speed is economy of motion, and exposure is everything in mitral. There is no margin of error in cardiac surgery. In minimal invasive, it is really almost none. So as a surgeon performing operation, doing a stitch, you know whether it is good or not. You cannot cut corners. It will haunt you at the end of the operation. Intolerance for imperfection, that is very essential. Then transparency with regard to outcome of complication. If you start, you will have complications because they are inherent to intervention. If you start, everybody will know that you have complications, because what we are doing, it is so dependent on a team of multiple disciplines that it is visible. So form a team and discuss these complications with the intention to improve. That is very, very important, because then you get the support of your team. And lastly, you need to use a formula of success for your program. And one of the formula of success that I think we have a good experience well is that you have to go beyond only the operation, but the whole process of care. Make a team, focus on a pathology, not only a technology. Focus, think of the endoscopic mitral, anything, as a tool in a toolbox to help your patients. So at the end, the endoscopic technique is a tool in a toolbox, and the future is smart surgery formula. So working with a dedicated team, using technology to tailor your tool or procedure to the anatomy of the patient, and use simulation for training, for predictability, for reproducibility, even as a tool for starting surgeries. So by saying this, on the 27th September 2020, we organized the first Maastricht Mitral Masters webinar. Emma, this is a promotion video that I did.
Sir, audio is not there.
So we can't hear the audio in this promotional video.
Oh, sorry.
Yeah.
So, sorry. So the second Maastricht Mitral Masters is being organized on 24th of January. And this is the faculty, a very prominent faculty. There is a registration is mandatory because we do a live surgery, and this part is intermediate and complex cases. There is an early registration fee, but as I talked to you earlier, I told you I will provide free registration for residence fellow and non-senior surgeons through your organization. They can register themselves by January 15, and if you provide me with the list, this is the website of the webinar that they can go and visit. So thank you so much for for having patience to talk to my talk.
Great, Dr. Payman Sardarinia. This was a great exposition of the techniques where we are and where we are going to move from here. I'm sure our youngster will get stimulation from your gracious presence. Let me now introduce our learned panel who are going to discuss this part of the the seminar. We have Dr. Satki Nambala. He's a senior consultant cardiothoracic surgeon, Apollo Hospital, Bangalore. Then we have, he's also the part of a scientific committee. Then we have Dr. Professor S.K. Agarwal, who is the professor department of CTBS, Sanjay Gandhi Medical Institute, Lucknow. Then we have Professor Devaguru, he's a professor of Department of CTVS at All India Institute of Medical Sciences, New Delhi. Then we have Susan Mukhopadhyay, Director and Head Department of Cardiothoracic Surgery, Apollo Gleneagall Hospital, Calcutta. And then we have Dr. P. Chandrasekhar, Chairman, Cardiothoracic Surgery and Director, Cardiac Transplant Services, GKNM Hospital, Coimbatore. Over to our learned panel for their comment and discussion and any questions. And meantime, let me welcome Dr. Pavan Atluri from University of Pennsylvania. Welcome, Dr. Atluri.
Thank you, Dr. Mishra. Excited to join.
Right. Thank you. Thanks. So yes, our learned panel, please start discussion. And meantime, if I'm going to get some questions from the audience, I am going to put those two in front of Dr. Payman Sardarinia. Dr. Satiki, Dr. Chandrasekhar, Dr. Agarwal, Susan, we start. Whatever.
I think Dr. Chandrasekhar and Dr. Devguru should lead this because they do a lot more mitral valve repairs. Like Dr. Payman said, I really enjoyed your presentation. It's fantastic. The thought process of building a program. I think most of us as surgeons don't dwell on this. And I understand, I think that is probably our weakness because we all focus on only building ourselves and not the team. And what you've done is really, really fantastic. Dr. Devguru and Dr. Chandra, I think should take over.
Yeah. Thank you. Chandra, you go ahead.
Thank you, Satiki, and that was a very wonderful lecture. And like you rightly pointed out, he gave an overview of what the mindset should be and how to build up a program, right from preoperative planning, and stress the need that a minimal preoperative screening should include at least a CT scan. And yes, I do quite a good number of mitral valve repairs, both in the degenerative, ischemic, and the rheumatic. But I should admit that my experience in minimal invasive is quite low, and in endoscopic almost zero. I do not know. I'm sure Satiki is doing now total endoscopic mitral valve repair. But like he rightly pointed out in one of his slides, what is minimally invasive? I think basically we all have the understanding that it is a non-stenotomy approach, and then as we get better and better, probably the incision size comes down, and we get still better, it becomes endoscopic, robotic, and total endoscopic VATS. So looking at his practice now, probably from direct vision mitral access, which most of the minimal access surgeons in India do, I think they have moved far away, and I think it's time that we catch up and move forward so to endoscopic. And in this way, I think a familiarity with thoracoscopic procedures, endovascular vein harvesting, like hand-eye coordination, because we surgeons are so used to direct vision that this is going to be a big migration, for senior surgeons, particularly who are used to so much of direct vision. And I think this lecture was a total eye-opener, not only in terms of me, looking to, rejuvenate myself to do it, also to develop a team, because I am now in a senior position that I should develop a team which should take care of the entire needs. And his focus and his stress on the talk was pathology-based practice rather than a procedure-based practice. And I think many centers in India may not be amenable to take that level of practice, but I think to a large extent we can do that. And particularly in centers like Devas and All India Institute, they can definitely lead the way as a pathology-based practice. But I think Satyakin can highlight how much of surgeons have migrated from a direct vision minimal access to a total endoscopic in India. And I think I'm sure this is going to be the way forward. I really appreciate the talk, and I think I'm looking forward to registering myself for the webinar masters in the few weeks to come now. Thank you, Payman, for that enlightening lecture. Deva.
Dr. Payman, it was a wonderful lecture. It was a master class. I think our duty is to teach people to do mitral valve repair and gradually move to endoscopic mitral valve repair. One concern is we do not get as much mixed matters as we get rheumatic. So to start with, we started doing completely full sternotomy, feeling rheumatic repair is more difficult when we do, especially we do caudal transfer initially. Once we started putting artificial chordae, I think endoscopic is possible. To start, you should start with a direct vision, then move to endoscopic. Even in rheumatic, it's quite possible if you can master the putting artificial chordae.
I just want to thank you for your comments, and thank you for your generosity, all of you. I just want to emphasize why I'm very focusing on the word endoscopic. I think what you want to have, you want to have a reproducible technique in many patients. And using endoscopic technique is not about incision. Of course, if you use endoscopic, at the end, your incisions become smaller and smaller. But endoscopic approach gives a constancy to an operation. And what do I mean by that? Whether the patient is large, small, thin, your exposure is the same. And you know, in surgery, everything is about exposure. If you cannot see it, you cannot do it. I know that many prominent surgeons, they think that there is a transition, that you go through open procedure, maybe use a long shafted instrument during open procedure, and then you go to direct vision, and from direct vision to endoscopic approach. I don't think that you have many surgeons, once they are have already developed their learning curve and skills in direct vision, they convert to endoscopic. The reason for that is that you cannot escape your learning curve of learning endoscopic techniques. Doing an operation with long shafted instrument with direct vision is different than doing it and looking at the monitor. Obviously, this is a procedure or technique that you cannot develop in patients, and nowadays that we have availability of simulation, you can develop those endoscopic skills. So I would say nowadays is actually possible to learn the skills endoscopically and start also endoscopically. Obviously, you can still do a part of operation with the direct vision, but the repair of the valve, the approach of the valve should be endoscopically. And that is also based on my experience and giving training to many surgeons on simulation and so on.
So Dr. Payman, in effect, you're saying that if you have a trainee surgeon working under you, he starts doing it endoscopically from day one, with your assistance, of course.
Yeah, because in endoscopic approach, even they can see at the much better what I'm doing than when you do it with direct vision or even sternotomy. So because of the fact that we have simulation, because of the fact that they can see what you are doing, it is much easier to teach them. There is one issue that I think that should be emphasized. I don't think that this is an operation that should be done by everybody. As I emphasize, the association with volume and outcome, the thing that you need to focus on a pathology, especially with the complex procedure that with many layers. If you want to focus on mitral and you dedicate yourself to mitral, everybody can learn the procedure and start the program. But you cannot do it in a way that some surgeons advocate. I am a minimal invasive surgeon, so I can do everything minimal invasively. And minimal invasive is an approach. So you have to focus on pathology. You have to consider the whole trajectory of the patient from start to end. There is a difference between a patient without symptoms in the earliest stage of mitral and those with heart failure. There is a whole heterogeneous group of pathology, but also how the patients are referred to a program. So this is not about a technique. This is about a tool that you have in a toolbox. So, for example, we have the beating heart mitral in neocord procedure, TMVR, endoscopic mitral, and then we have MitraClip. So you have to see which patient will benefit and which patient is suitable for what you are doing. And you need, for that, you need to work in a team.
Thanks, great. Dr. Payman, you know, you have now put us in a situation where the surgeon like you and the surgeons who are using robotic tools, there is now going to be a kind of, you know, the debate. So which one is going to be more intuitive and very surgeon friendly? One has to see the cost of equipments and one has to see the learning curve. Like in we are old-time minimally invasive surgeons who started very early on, and we were trained in NYU and subsequently in Leipzig kind of tools. And we are very comfortable, you know, go on doing mitral valve surgery, aortic valve, minimal invasive, and multivessel, you know, with the direct vision. Now, the issue is that I want to go to the next level. If I may not go, some of my team member can go to endoscopic, totally endoscopic. Though I am trying and learning from some of the, you know, the people even from Sataki to again, I am old-time a robotic surgeon. Put a lot of things in 2002 to the CABGs. Now I'm going towards the mitral valve or ASDs with the robot. But I want my team members to go into the technology which you are using. So what I have done, and this is for a discussion, that I ask my team member to participate in endo-vein harvesting. My unit, like in Chandru's unit, we are 100% endo-vein for harvest of the saphenous vein. So we do have a PA, but now I have recruited my junior surgeon to take down the you know, the vein with the endoscope so that he can get a feel of the monitor. And this I'm going to have a kind of experiment whether he can be able to adapt the endoscopic mitral valve surgery or ASD with this exposure. Your comment, please, on this one.
Yeah, of course,
but we don't have a simulator. So instead of simulator, what I am now using is let him see the monitor, see the veins, and then he can go on to the intracardiac structures.
I think everything that is in the same kind of philosophy that would help skills development. But at the end, I think that you will need a deliberate, dedicated way of training people.
Right.
And I give you an example because I showed you a map how you put sutures endoscopically for every corner, which position, in which order. That is all taught on the simulation done in a patient, and then also I did train surgeons in a way to see, is it teachable? And now every surgeon has a map in his or her head. So I'm not going to say that this is an ultimate method, but it's about the way of we standardize surgeries or procedures. You know, if you have a surgeon even who has managed the skills of working with long shafted instrument and managed the skills of putting stitches, looking at the camera. Still, when you start, you are going to have to find out for yourself which order is the best, which position is the best. And this is like, it's not a rocket science. I mean, you can imagine that it is not an efficient way of starting a program of teaching somebody, that you have to do 20 cases. At the end, you create your own map and then you go further. And that is actually for everything, I think. So what I think is there should be a deliberate way of teaching people. And we established surgeons, we have a responsibility, because I showed you there are more than 70 devices being developed and they are coming, and the cardiologist is going to use them. And you would say, and if you talk with a prominent mitral surgeon, and you say, yeah, TMVR, why we need TMVR? We have so good results even for functional mitral. But they think about themselves, their own position and their own results, because it is not about whether I have good results. It is about whether we as a community of surgeons have a good result for mitral valve repair and surgery. And I showed you all those things about what should the patients get and what they get in general. It is not so good. So that's why there is an incentive in the field of cardiology with many developments and new tools. So we have a responsibility to do a deliberate training of young surgeons for in new technology.
Great. Thank you. Thanks. We have to move on. So Dr. Payman, on behalf of society, on behalf of me and the scientific committee, which is Dr. Anvamule, Rajneesh Malhotra, Dr. Nambala, Dr. Ajit Vana, and all the leadership of Society of Minimally Invasive Cardiovascular and Thoracic Surgeons of India, we really thank you with the bottom of our heart, and we wish that you are going to be the part of this society in the future also. Meantime, I'm going to send the names of the interested people who has to be considered a free registration, and of course we are going to upload in my website, and we are going to communicate to the people in our group who can afford to pay for registration. Thank you. Please do stay for the next subsequent program. And now let me invite.
Ask one more question, please, for Dr. Payman.
Yes,
Just
please.
Dr. Payman, if we have to, if a big institution like like the R&D institute, your simulator, how much does it cost? And is it something that's available?
Yeah, so we have made a startup of the simulation from the university, and these things are at this moment handmade. So they are commercially available. It takes a couple of months to make them. Previous version was around between 30 to 40,000 euro, but now because of the fact that the new simulation is built for multiple operations, it would be make more sense for centers to acquire that, because it's not only for single procedure. The other thing is that we are trying to come up with different formulas to assist people with the simulation, whether it's leasing, lending, or so there are many ways to acquire a simulation. But what is also very important to emphasize, it's 1 minute, Jen says only. Simulation is good, but you need to have feedback. Without feedback, there is no constructive learning. And this simulation has an integral feedback, so it gives you feedback about the suture length, width, compare it. So because of that, the technology built in the system is very complex, and that's why it is costly. Otherwise, I think it would be easier to provide simulation without feedback. So,
thank you.
Thank you so much.
Thank you. Please do stay. And you have to make a comment at the end after presentation of Dr. Pavan Atluri, please.
No, I'm very eager to listen to the colleague from
so now,
US,
friends, let me, on behalf of the Society of Minimally Invasive Cardiovascular Thoracic Surgeons of India and the leadership and the program committee, welcome Dr. Pavan Atluri. Dr. Atluri is the Associate Professor of the Surgery at the Hospital of University of Pennsylvania. He is also the Director of Minimally Invasive and Robotic Cardiac Surgery Program and Director of the Cardiac Transplant and Mechanical Circulatory Support. Dr. Atluri is a very dear friend of mine, and he is, in fact, always forthcoming to help us. He was also participated in our earlier meeting. I have seen him operating a couple of times. The university where he's working, we all know. And the kind of work and what he does, we see the publications. We all know, we always quote the repair is better than replacements. You know, those papers which have come out from University of Pennsylvania, we all know. He happened to be to our facility for just visiting. And since then, this is around 15 years back, and we are friends. Now, let me invite Professor Atluri to talk about the basics, in fact, and also the technological evolution in the field of minimally invasive and robotic mitral valve surgery. Over to Dr. Atluri, please.
Thank you, Dr. Mishra. Let me share my screen. It's an honor to be here, and I wish you all a happy new year. I hope that 2021 will bring us more hope, more promise, and a return to normalcy. I personally have gotten the vaccine 2 weeks ago, and I hope that the rest of you are all in line soon for the same. So, well, without further delay, let me get started with my presentation. I've got a tough act to follow. Dr. Sardi, thank you very much for your knowledge. And without further ado, here's my slides.
Yeah, we can see your slides, please.
You can see them? Perfect.
Yes, yes.
All right. So I think that it's important to understand that what we're talking about when it comes to minimally invasive is really a short-term benefit, and there's a very significant short-term benefit that we've all appreciated with MIS. So what are those minimally invasive, the benefits associated with minimally invasive approaches? And I think they can be broadly categorized as rapid recovery, including lengths of hospital and ICU stays, rapid extubation, rapid return to activity as well as life, decreased rates of blood transfusion, decreased pain, cosmetic, and then potentially decreased rates of atrial fibrillation. Now I will say, and I won't belabor this because I think Dr. Sardi did such a wonderful job of going over the data, but really it's all about long-term outcomes, if you ask me. Any procedure that we do, we as a field are obligated to maintain optimal long-term outcomes, those outcomes that we know that we can provide with our operations need to be translated to the minimally invasive platforms that we choose. This data, again, not to belabor the point, but has been demonstrated by Tyrone David several years ago, which demonstrated really excellent 20-year long-term durabilities of repair. And these have been further demonstrated by other groups, including Michel Debonis's group from Milan. So contraindications I will submit to minimal access approaches to the mitral valve are really a factor of surgeon experience and comfort, as well as patient comorbidities. So while you're trying to start new minimally invasive programs, I would submit to you to consider your own skill, your own comfort with, in this regard, the mitral valve. I think it's critical that surgeons who are trying to translate their skills to the minimal access approaches have a really in-depth understanding of mitral valve pathology as well as repair techniques, and along with that, to couple that with surgical complexity as well as patient risk factors. And then I would submit that if you're starting programs looking at minimal access approaches, that you in your own mind develop a schematic of what you think in terms of complexity or repairs. This is just one that I made up. I'd started with type 1 annular dilatation, which would, or Carpentier type 1 annular dilatation, which are largely treated with annuloplasty devices, P2 prolapses, which I think that many of us have many different repair techniques and can reliably repair a P2 prolapse, and commissural prolapses, bileaflet prolapses associated with Barlow's valves, and then potentially anterior leaflet flails. But in your own mind, determine what you think of in terms of increasing complexity. And I would submit that you start with the lower complexity operations, much like Dr. Sardi so eloquently elaborated in the prior talk. I'm going to skip past these slides that you just saw about predictors of mitral valve repair and surgical experience. And again, I'm going to start off the rest of my talk. I'm going to really focus on sort of practical approaches to developing a mitral valve program and practical approaches to repairing the valve. But I'm going to submit to you that the key factor that we are all obligated to provide patients with is a valve repair when repairable. So a true comfort with mitral valve repair is critical to effective translation of therapy to the minimally invasive setting. We published this paper several years ago where we looked at MIS versus open sternotomy approaches and noted that we had equivalent results for surgical repair of mitral valves in a propensity matched analysis with really excellent repair rates with good long-term durability. Mark Gilanoff and colleagues from Cleveland Clinic presented their results with robotically assisted approaches of their first 1,000 cases and noted, again, really excellent outcomes with 99.9% survival and 99.5% repair. So really, this is the benchmark that we need to work from. So what is our approach? Our approach, all patients will have placement of a double lumen tube. We place the PA catheter, which is placed by the anesthesia team, and utilizing ultrasound guidance, modified Salinger technique, a 16 French wire-wrapped cannula is placed. Some places I know have surgeons place this, or the surgeons place it themselves. At our institution, given the high volume of minimally invasive mitral procedures that we do, our anesthesiologists have gotten very comfortable placing these large bore cannulas via the right internal jugular vein into the superior vena cava. And I always have bicaval drainage in all my cases. I find that there's no variability. It really decreases blood within the field and keeps the heart decompressed. Whenever you think about it, if the right heart's not decompressed, what you'll notice is that your ceiling seems to drop in your field. So drainage is of the utmost of importance of the minimally invasive approach. I know that many people are converting, especially in the United States, from a cut down to a percutaneous technique utilizing perclosed devices to close the femoral arteries. I will say that probably 10% of the time I very carefully place my femoral arterial puncture sites based on either posterior wall calcification, other abnormalities within the wall that I rely on tactile feedback. I will say that it's very, very rare to have any complaints from the femoral incision, which we keep quite small, and you can see here how small it is. It's really the length of both cannulas that go into the groin. I traditionally, in 80 to 90% of my procedures, will use the endoaortic balloon. And so I place a 21 French cannula in usually the right femoral artery. I find it easier for endoballoon placement. And then I always utilize a 25 French. And for me, I use the Medtronic femoral venous cannula placed by Salinger technique with TE guidance from the femoral vein. So at the end, before I get started, here's my setup. There's the IJ cannula. There in the SVC, there's like my long femoral venous cannula from the groin. I utilize an endoaortic balloon, and then I use femoral arterial cannulation. I do utilize single lung ventilation. Some people will do this with a single lumen tube and just drop the lungs. I find it a little bit easier, and it saves me a couple of minutes in the operation to use single lung ventilation. I use active venous drainage with vacuum assist, which is really commonplace nowadays. I flood the field with CO2, which I'll show you shortly. In terms of occlusion, which I'll go over in just 1 second, I tend to favor endoaortic balloon. I will show you some data that this is a very experience dependent technique, which does have a learning curve. In the era of deltoid cardioplegia, I do not place a retrograde cardioplegia catheter, which now Edwards which has taken over the old HeartPort technology platform. still does offer. And I use TE, of course, for all line placements. So incisions really in the fourth interspace. I will tell you, when I first started like 12 years ago, I used to be very precise about counting interspaces. Now I literally put my hand on the lower costal margin up by the clavicle, and pretty much the midpoint of where your two fingers will meet will end up in the fourth interspace. If you, once you make the skin incision, you can feel that the third rib is a little bit flatter. And the third interspace is a little bit larger than the fourth interspace. The ribs continue to get progressively smaller. Once I enter, I actually tend to use this Alexis soft tissue retractor over the Edwards retractor. I find that it actually opens the wound a little bit broader, and oftentimes I can avoid using the metal retractor. I utilize a 5mm endoscope, placed also in the fourth interspace, and I do this all endoscopically. And then in the sixth interspace, I place the CO2 port, and I learned that from Hugo van Eerman. And I tend to bring the floppy sucker in through that port. And here again is the groin cannulation. So in terms of aortic occlusion, this is what I'm really reliant on. I will say at Penn, we've got a very large group of cardiac anesthesiologists, but I've got a very small group of cardiac anesthesiologists who actually work with me on these procedures, because I am so reliant on their ability to show me where this balloon is and ensure that I'm in the right place. So what I really like to do is place this at just above the sinotubular junction. If it is up against the aortic valve, it's an absolute nightmare. Because what it will do is, again, close a ceiling in up by the anterolateral trigone, and it will close in your field of view. So it's really critical it's placed appropriately. Additionally, when you place your trigonal stitches, if that endoaortic balloon is too low, you will risk puncturing the balloon, which I have done on more than one occasion, unfortunately. And then, of course, the tried and true, the chipwood clamp. I place this catheter, I place it very low. I've actually switched over in the era of, the core knot, that I actually use a 2.0 tab deck. I use my annuloplasty suture in a pledgeted fashion. At the end, I just take the needle out and I choose a core knot to secure the site. And it seems to work very well. I think Dr. Sardi pointed out, it's very important that you identify where that pulmonary artery is, the RPA. And the cannula basically goes right on the inferior border of that RPA. And you really do need to make sure that that you identify the left atrial appendage, because it is very easy to capture in the clamp. And that's one really quick way of converting a very beautiful minimally invasive case into a sternotomy operation. So the endoaortic balloon, just to give you a little quick glimpse of it, it is a balloon which has really got two ports. It's got the end port, which is utilized for both your root vent as well as for cardioplegia, as well as a second port, which allows the balloon itself, which I showed you, to inflate. I will say that it's very much like a kite in the wind. So once you inflate that balloon, while you're giving cardioplegia, it'll tend to kick the balloon away from the aortic valve. The moment you're done giving cardioplegia and you're back on bypass with all the pressure driving towards the aortic valve, the balloon will slide down. So I tend to place this balloon up higher. I utilize bilateral A-lines, which allow insurance that I'm not occluding the right innominate artery. I start off by quickly injecting 30 milligrams of adenosine the moment the endoaortic balloon is up, which gives you a nice quick cardiac arrest. And then subsequently, I give 1,200 cc's of del nido cardioplegia, which helps maintain myocardial protection. And that is really important in terms of maintaining balloon position so you don't get a motion in that balloon. So in terms of my occlusion choice, I get CAT scans in all patients, make sure that the femoral arterial size has a minimum diameter of 7 millimeters in order to be able to place the 21 French femoral arterial cannula that is required. And so additionally, we'll determine whether patients have small or large BSAs. I found that patients with BSAs less than about 1.6 or lower, even if their femoral arterial size is appropriate, their entire arterial tree is small, Once you place the 21 French cannula and then you put the endo balloon through the tip of it, line pressure is really very high. And often I'll tend just to give up on the endo balloon given the high line pressures and have to put a Chitwood clamp in. So usually in small patients, I'll tend to shy away from the endo aortic balloon. In terms of redos, I think the endo balloon is a godsend. Allows you to not have to dissect out the root, and plus you can still have a stable field or a still field. Every once in a while, you'll find that the endo balloon will tend to go up the left subclavian artery, in which case you may not be able to use the endo balloon. There's a cost associated with the balloon. It's about a $3,000 balloon, so cost is a real consideration. And looking at our own experience, and at the time we've done about 875 cases. We're up to about 1,700 cases now. When we looked at our experience then, we noted very similar cross-clamp time, bypass times, conversion to sternotomy rates. We had no lower extremity ischemia. And when we looked at our dissection rate, early on, we had a dissection rate of almost 3% in the first 100 cases with the endo balloon. So there's a very significant learning curve. And hopefully the knowledge gained from prior generations can really help us minimize that for future surgeons. But really, in the last 500 cases in the study, we're at about a 0.6% dissection rate. And currently, we're approaching 0.3% actually in our latest series. What we noted was there was really no significant difference, though, between the endo balloon and Chitwood clamp in our overall cohort in type A and type B dissections. And whenever I think of minimally invasive approaches, the added risk with peripheral bypass is really the consideration. I always think about vascular injury and whether the patient has comorbidities that would subject them to increased risks of aortic dissection, lower extremity ischemia, paralysis, stroke. And then, of course, we know that there's longer operative times, as well as the potential for phrenic nerve injury. And really, I don't think you will ever resect, correction, or transect the phrenic nerve because it's very easily visualized. The bigger worry is a traction injury from the tension on those pericardial traction sutures. So my contraindications that I would submit to you early in your training would be an aortic disease. Ascending aortic dilatation greater than 4.4 centimeters should really be a contraindication of the endoaortic balloon. Moderate severe aortic insufficiency, in which case you, of course, would have to potentially deal with the aortic pathology as well. For acute endocarditis, the one limitation with the endoscopic approach I find is subvalvular right at the annular level, right under the leaflet. So if you're worried about a lot of disease right at the annulus, behind the leaflet, you may not be able to see that. You may not be able to fully debride. Of course, I'd say the primary tenet of acute endocarditis or management of any endocarditis is full debridement of disease. And then a stable repair following that. I tend to repair about 80 to 85% of all endocarditis. And so I'm very aggressive with repair techniques. And so if someone's got a lot of bulky disease on the mitral valve, I'll tend to do it by sternotomy. Severe MAC, when I'm referring to severe 360 degrees or 1 centimeter thick MAC, I really rely on my hand there to be able to get the suture through the calcium. And a paper was recently published in the Journal of Heart Valve Disease. And for those severe bulky MAC cases, you're probably best off trying to do it sternotomy so you can get a really stable valve placed. Concomitant coronary disease, we have done some with hybrid angioplasty. I will tell you, we've had enough bleeding that I'm not a huge fan of LAD stents. And I think the benefits of an LAD or Lima to LAD really do outweigh the PCI. That those patients should probably get a Lima to the LAD and a mitral valve repair. Again, think of long-term outcomes. And then some systemic disease considerations. And I will submit to you later that I think some of these very complex patients you can still do by minimally invasive approaches. So all patients, I always get a TEE, and I look at the mitral valve pathology. I look at the aortic root, including both diameter and calcification, the aortic valve. And then one thing that TEE will show you that CT may not is that bulky mobile atheroma. So I rely on TEE to look to see if there's any mobile atheroma that may be a contraindication to femoral cannulation. I get a CTA in all patients, and I will tell you that it's interesting. Every once in a while, you'll find an aortic dissection related to a cardiac cath. In this patient, I found both an aortic dissection as well as an occluded, an iliac dissection as well as an occluded iliac, which of course would have been a nightmare had I not known this up front. and then a cardiac cath. So these are my 3 core studies before any minimally invasive, and I mean both port access as well as minimally invasive approach. I thought I would show you a quick case that I did, and the patient had a prior AVR, and there's a few key points that I will show you through this. So this is a redo. I did this with an endoaortic balloon, and I think, once you go up the learning curve, you'll realize that there's really not much that you can't do by a minimally invasive approach. For these redos, I always put 2 retraction sutures to retract pericardium, and where I think is a soft spot. Every once in a while you will accidentally get into a right atria, but for the most part you can avoid this. Once you're into the space, you carefully dissect, and very much utilizing surgical principles, dissect where you see open space. I tend to use a combination of blunt dissection, a little sharp dissection once I'm in. Nice thing about this approach is if someone's had a prior CABG, you can tend to really just avoid all the anterior adhesions and come in just laterally underneath the grafts. So for my endoscopic port access approach, I tend to place 1 suture anteriorly and 2 sutures inferiorly. You see here just a little bit of sharp dissection utilizing electrocautery. Move this along just a little bit. So once you've got the dissection done, I place my 2 pericardial retraction sutures. I define the AV groove. I will tell you, as a resident who learned how to do this at a center with high volume sternotomy mitral surgery, we tended to dissect the AV groove a lot. I stopped developing Sondergaard's groove too much. I will define where I want to make my left atrial entry, and then I will define the sinus, and that's it. What you'll find is if you dissect this groove too much, you'll end up with a big flap of tissue, and your closure will become the most painful part of the operation. And I realized this even more once I started doing this procedure robotically. So dissect the groove just as what you need. The redos, you'll find sometimes the fat you'll have to pull up a little bit more. You don't want to be on the pulmonary veins, but a few millimeters away from the vein is all you really need to be. And then I tend to do an atriotomy. You can do it through 1 of 2 ways. I've learned minimally from a robot that you can get in with the electrocautery. Oftentimes when I'm doing this endoscopically, I use an 11 blade. I utilize a sucker. My assistant's now holding the sucker to hold up the top of the atria, and then I use sharp dissection. You don't need too much of an opening in the atria in order to actually get access to the heart. I always tend to put this suture in the anterior cut edge, and that really allows nice retraction, especially at the end when you're closing. The other key is when you bring this your left atrial retractor bar in, I think it's critical that you end up right down the middle of that left atrium. If you're skewed one way or the other, your view will be skewed also because your atrial opening is going to get skewed. This was actually with the old, I think this is the old Edwards retractor here. I've tended to switch over to the newer Edwards retractor, which actually has got a lip that will allow it to move down and up. But what you'll see is this is a patient that had a prior AVR. And what you notice is that once you're coming at it from the side, you can really get really beautiful views of the mitral valve. And this guy that had an anterior leaflet prolapse with ruptured cords that we repaired. So 4 weeks post-op, these patients tend to do very well. Incisions are healed very well. At the end, I'll talk to you about my anesthetic regimen and how we've changed to minimize narcotic use. More and more, we've switched over to the robotic platform. I will submit to you that young surgeons, and I've heard Hugo van Eerman say this, that the robot is a great neutralizer, and I tend to agree with that. For those of us who started doing this endoscopically and then switched over to the robot, it actually creates a little bit of a hurdle. You actually need to forget a little bit of port placement, et cetera, that goes with endoscopic approaches when you do the robot. It's really critical that you're sitting right lateral, as far lateral as you can go with the robot. Why is that? And the really critical part is the camera. You want that camera lateral and being able to look right at the valve. Otherwise, you'll feel like you're sitting on your head, or that your camera, you're looking top down, not the view that you want. But I tend to use this sort of port placement. This is now, of course, the ports for the DaVinci Xi. These are 7mm ports, about the size of a pinky or so. I tend to use a 4cm incision. And you'll notice here's the anterior axillary line. I place this incision right on the anterior axillary line, about 1.5 finger breadths up. I place the camera port still in the 4th interspace. I know some surgeons advocate for the 3rd, like Didier Lumet, who I saw do a bunch of these not too long ago. Didier and Jean Grassi like to go into the 3rd interspace at NYU. I will say I felt like I was working a little bit around the corner. After I came back, we did a few 3rd interspace. I tend to like the 4th personally better, but that's a comfort thing and a preference thing that everybody will need to figure out. But a 4th is pretty reliable. Put you right on top of the veins. Your veins will be basically, if you put the camera in, you'll be seeing it just above your incision. Then you'll know you're pretty much in the right place. I put the right arm port in the 6th interspace, put this down nice and low. If you're going to use an endo balloon, not as critical in terms of height of this port, but I place this in the 3rd interspace. If you're using a chitwood, when the endo balloon was off the market, we were doing basically all our cases with chitwood. The chitwood clamp, you want to leave room for it. And remember that the robot has got an arm that will have dynamic motion to it. So you want to place that chitwood clamp low enough so you'll not be constantly bumping into it. I put a camera port, as I said, still in the 4th interspace. Different than the endoscopic port where we put it down low, we put it up top here. And here's the left atrial retractor space. And I get this over as far as I can, close to, again, in the 4th interspace, as close to the sternum as possible without hitting the mammary artery. And for that, you could use the camera and look straight up and see exactly where your mammary is and avoid it. And the nice thing about placing this further away is you're going to take your ports, you're going to separate them out. You really want at least 2 finger breadths between your ports so you don't get a collision. Ideally 3 finger breadths between them. And that way the robot collisions won't be there. If you're utilizing the DaVinci Xi robot, which is the newest robot, placing those ports closer is not quite as big a deal because the robot has been designed to manage conflicts. But what you'll notice is that both your camera and your atrial retractor will be more and more parallel the closer they are together. And I placed this CO2 port very low, and you'll notice the floppy sucker that goes across it. The robot really gives you ideal views, and you'll be able to do most every operation with the robot, really all pathologies. And I will submit to you that once you're sitting at that console, I won't even be able to do justice for the visualization that I get in this 2-dimensional visualization, because the pseudo 3D binocular vision that's provided in the console really is wonderful. So here's a case. I thought the easiest way to maybe walk you through some of the techniques is with the case. So much like endoscopic, the phrenic nerve you'll see is right here. You want to make sure you avoid it. And I go really high, both for my endoscopic as well as my port access approaches. Make sure that I have lots of space. And again, this comes from wanting to protect the phrenic nerve. Place the sutures in the same exact place. So this suture will go pretty much right where your groove is. You want it on the lower side. The key to any robotic approach is really it's a 2-surgeon operation. Whether you want to train a physician assistant or your second surgeon, I use one of my partners. The 2 of us have developed this platform over the last 15 years or so. Tend to work together, and it's really, the key is that you work in unison. This top retraction suture I placed right where the RPA comes underneath the SVC. In terms of the pericardial opening, the critical portion is I'm using an endo balloon in this case, so I don't have to open it more. If I were going to use a chitwood clamp, I would open the pericardium more. What you'll notice is I haven't dissected the groove too much. I bovie right in, I go up. You can make that cut up until, you'll notice that you can keep cutting superiorly until the tissue starts curving. Do not cut once that tissue starts curving. Cut only on the anterior portion of it. Because at the end, if that tears at all, your closure will become a nightmare as you're trying to look around a corner trying to close it. Here's the sinus. And you don't really need to cut too much, because once the retractor goes in and your camera is in, your visualization is actually pretty good. So I take this just about, again, just the anterior surface. What you see is that then here's the mitral valve starting to come into view. And then we're going to put the sucker right in the left-sided veins. My assistant has handed me the left atrial retractor. One of the beauties of a robotic approach is that you've got a dynamic left atrial retractor that you can constantly move for you. It's really two arms. I tend to use an offset retractor where one arm is longer than the other. There's two forms. What you'll see is a really excellent visualization. What you'll notice is that the wrists are back. We're humans. We're used to using our wrists. We're taught to use our wrists to throw stitches, enter tissue 90 degrees. And the robot really gives you that back. So that's why I call it the great neutralizer. You don't have to worry about the dynamics of long shafted instruments. You're back to being able to use your wrists just like you do any surgical approach. The instruments, the downside of these instruments is they're multi-use yet limited use. And this is where the company partly makes back their money. You'll notice I do not change my repair techniques based on how I do the operation. I do about 90 mitrals a year, and whether I'm doing it sternotomy, port access, or robotically, they all get done the same exact way. I tend to use a combination of traditional Carpentier techniques. With resection, I do a fair amount of neochordae, but I always think of the valve from a pathologic standpoint, what I think will provide the best long-term repair, and I apply the same techniques no matter what my approach. You'll notice that with the robot, you can really throw absolutely the same stitches you throw sternotomy. So your wrist is back. So again, core principles, enter the tissue 90 degree in a hard turn. Same thing I teach my fellows on a very regular basis. We've tried tying in the field. I'm fortunate, I have a very good bedside surgeon, and I've also trained one of my physician assistants who I trust completely to tie these knots for me. And so we use the same knot pusher we do with port access. I tend to sometimes run these stitches and sometimes do interrupted stitches. And I interrupt the stitches if I want to really make sure I get a perfect lineup on my repair. The more I think about this particular operation, I probably would have resected more. You'll see at the end. It was okay. It was a beautiful result. Patient's doing well long term. I probably would have taken a little bit more to drop the height of this one part a little bit more. So I don't want to sugarcoat it too much and tell you there isn't a learning curve. While we're watching this, I'm going to tell you there's a significant learning curve with the robot. It's probably about 50 cases. I will say that there's many things that you can do. The robot itself comes with a built-in simulator, which is actually very good. So I did a lot of that in my training. I actually used just a plain thorax model and mounted pig hearts in it and did a lot of pig hearts. I probably did over 100 pig hearts. And then there's a lot of different exercises that you can do. It's all about just getting comfortable with your wrists. So I was peeling grapes. I was building paper mache airplanes. And it's all about just having access to the robot and just getting really comfortable with the robot. And part of the training can't be just a surgeon when you're talking about robotic procedures. We trained the bedside scrub nurse. We trained two physician assistants, and then the two surgeons, myself and my partner who did this. Our operative times have gotten very similar between port access and a robotic approach. So once you're over a learning curve, you can really neutralize it. I'll move this along a little bit just so I've got time for other videos too. But you'll notice it's really a true symphony between yourself as well as your partner. It's much like a dance. We've got these specially made sizers that we utilize. We utilize these for all our port access cases and also for robotic cases. Allows us to vary size nicely. I always, whether I do port access or do the robot, start at the anterolateral trigone. The key with port access is then I use the Van Aerman needle. I actually utilize it as a needle and pull the stitches over. Because Dr. Sardi is absolutely right. If you don't pull those stitches over, what you will end up with is a bunch of suture right down the middle of your camera. My stitches, everybody's got their own personal preference. I tend to do I go from anterolateral to posterior medial when I do it robotically. Otherwise, if I do it endoscopically port access, I place these first 4 stitches right to about here, pull them over with a needle, and then I start up at the anteromedial triangle and I come around. In terms of valve choice, I tend to use a posterior band. I'm going to show you some data. When I looked back retrospectively at our database with about just under 10,000 mitrals, and why I've made some changes to my practice. But for any posterior leaflet pathology, Barlow's, I tend to use a band. For any patient who's got anterior leaflet pathology, I use a complete ring, and more recently I've switched over to a complete rigid ring. I tend to use the Edwards Physio 2. We've done this where I've put the ring in place and sutured it in place. I don't love the way that every once in a while, it just doesn't seem to line up as symmetrically. So over years, we've learned to place all our sutures and then drop the ring in, much like you would either port access or with open surgery. And then real game changers have been utilizing the core knot. So I will tell you, I pretty much use the core knot on all my valves nowadays. I know there's a cost associated with it, but especially with AVRs, and we've got a very large training program. My fellows are pretty much throwing all the stitches when it comes to the minimally invasive and open case correction, the mini AVRs, as well as the full sternotomy AVRs. And so for those, I just find I'm more comfortable letting them not have to tie across leaflets and get a bigger valve in, so you could actually get the valve seated perfectly. So, so here's valve post repair. And then always put a vent across the valve. And this is just as easy to do with a replacement as well. I always tend to start at this bottom inferior edge, a standard closure. Then my bedside surgeon will tie the knot. More and more, while we're watching this, I will say we're starting to work with a thoracoport, which is just a little sort of 3 millimeter port that you place, and because all you really need the access port is to hand the equipment through, and the limitation will be the ring. So as long as it's big enough to get the ring, because once you have the camera in place and all your arms in place, you can't really even see through the port. You're fully reliant on endoscopic visualization. The nice thing is here is we throw about 2 to 3 stitches, and then the whole time my assistant is just hooking the suture and pulling it up. So I'm never giving up the needle, which helps continue with efficiency. The nice thing about endoscopic and port access is you could really see the veins. You see that I'm sewing pretty close to the veins here. I've got a very small margin. But the nice thing is you don't see a big veil of tissue that I'm having to push up with another hand, which I think really helps. So recently we just presented our data at the last EACTS meeting, where we looked at our mitral valve operations and looked at those patients that excluded those patients with previous pacemakers. And then we looked at those patients that either got a pacemaker or didn't get a pacemaker. And we did a nearest neighbor propensity matched subgroup analysis. What we found was that those patients that had a band had a significantly lower pacemaker rate at about 1.9% versus those that got a complete ring at about 5.8%. And this also bore out with a multivariable regression analysis, where we found an odds ratio of almost 3 for pacemaker and utilizing complete ring versus bands. So since then, I've been more and more cognizant about utilizing bands as well. What you'll notice is the robot will really give you exposure and approach to be able to do other cardiac operations as well. I've done, you can really do most operations on either the atrioventricular valves or ASDs, myxomas, etc. So here's a patient that we did a mitral maze on. and we utilize the AtriCure clip. We do not utilize the V clip because I'm not always confident that I'm across at the base, and I think there's been concerns. So we use the complete minimally invasive clip. What you'll notice is a push up with the aorta with one hand. You can do this port access as well, by the way, which we have done. The key here is this maneuver here where you grab through. And I used this example because you'll notice that we tore the atria, but I specifically use this example because you're going to notice the blood, but the clip is actually wonderful. So if you ever have a left atrial injury, you can throw the atrial clip on it, and for in more advanced scenarios, and treat the bleeding that way. But so now we've deployed the clip, you release it, and you could really make sure that you're right at the base here. And I tend to use the endoaortic balloon. So I haven't inflated the balloon yet. Some people will actually inflate the balloon. I tend to not want that aorta to be plump and filled up. The balloon will stretch the aorta just a little bit. And there's the clip. The clip has been deployed. Left atria has been excluded. So that's always a very nice way of doing the first part of the Cox-Maze 4 cryoablation. And here you're just quick images of the coronary sinus lesion. Here's the lesion to the mitral annulus, the pulmonary vein isolation. I learned this and talking to Pat McCarthy, who's of course been a giant in the field, and he's managed to minimize and eliminate one lesion. And what I normally have learned from him to take this pulmonary vein lesion, this from the inferior aspect, and I hug the left atrial appendage. And this way, what I'm basically doing is both doing a PVI as well as left atrial lesion at the same time. And then here's from the superior aspect. I tend to use the AtriCure cryoprobe because I'm in a tight space. I really like the thawing feature, so the automatic thawing that's built into this. And I do each lesion for 2 minutes and can get very reliable results. Here's another example of a patient that had an anterior leaflet flail. You notice a very extensive flail here. And you see again, the anterior flail, see a lot of MR. Patient was very symptomatic. So once we got in, you'll notice ruptured cords. Pretty typical anterior leaflet flail. And what I want you to appreciate here is really the beautiful visualization you can get of subvalvular apparatus. And don't forget, this camera is mobile, so I can drive this camera all the way in and it won't be in my way with my instruments because my instruments come from the sides and I can work right around it. There we go, driving in, constant adjustments. And don't forget, I'm also looking at this in three-dimensional or pseudo three-dimension binocular visualization, right? And I really like Dr. Sardi's idea of exposure. There's also, with the endoscopic port access, there's also a retractor made by Felling. I will say there's a cost associated with that retractor. It's just a metal strip that you can place and open up the space. I tend to use that when I need to, on a port access operation, get subvalvular. You'll see though, again, 90 degrees in, I'm able to use my wrist and really get a nice stitch into the papillary muscle head. Great point that Dr. Sardi made, which is respect anatomy, right? Respect geometry. So you'll notice that I'm driving into the anterior head of the posterior medial papillary muscle. Be careful of suture orientation. Again, 90 degrees in. Drive the camera in as much as I need to without disrupting my working space. And then here's the anterolateral papillary muscle head. Again, identify the appropriate papillary muscle head. And then the other key is not only respect the appropriate papillary muscle head, you really want to respect geometry in terms of where your cords are coming. What do I mean by that? If you look at the anterior leaflet, there's going to be cords that come from the lateral aspect, cords that come from the medial aspect. You do not want to cross the midline. There needs to be an imaginary line drawn right down the middle of that where you put your cords. I tend to go figure of 8 around the papillary muscle heads. And then going in probably about 1 to 2 millimeters, I'll go figure of 8 around the leaflet where I want to support the leaflet on the anterior leaflet. Posterior, you can go back a little bit further. This will actually define your line of coaptation. So posteriorly, if you want to roll the posterior leaflet further, you can go back just a little bit more. Again, this is my bedside assistant who's helping navigate the suture, helping manage the suture, getting rid of slack. When I'm driving Gore-Tex, the CV5 Gore-Tex through the leaflet, and this is the longer Gore-Tex suture, there's multiple lengths. For the robot, you will need longer length, and you'll also need the longer core knot, just given how far away you are with the incision. I place a figure of 8 through the tissue itself. This is, and then we tend to size in terms of length. There's multiple ways of doing this. One is to pressurize the valve and then secure the height and then sew it. The other, there's a valve that came out a few years ago by Levanova, the 4D, I think originally they called it the Memo 3D Record. And what you realize with that is what you want to do is size basically to the back of the posterior annulus. Why is that? You need to always think of that ventricle distended and the papillary muscle moving away when the maximum stroke volume is there. So after a while, you can actually figure out what the right sizing is of that with experience. Otherwise, I would say utilize all the tricks that are out there. Utilize that record ring. You know, everything is fair game when you're trying to end up with perfect results, right? And technology can really help us get those perfect results. The other thing, we tried some of the Cordex, the pre-measured cording, didn't love it. It almost seemed more cumbersome because there's a lot of suture that you have to manage. And with the robot, it got really cumbersome, even with port access. So I've shied away from it. And you'll notice that I use the robot arm. I lock in exactly where I want the suture. And then I tend to have my bedside assistant secure, stitched. Again, place the sutures, same fashion. Here I've placed a complete ring. Just as easy to place those sutures anteriorly. And I'm going to, the ring is down, I tend to move. And you'll see the repair was, the valve looked quite good when we're done. I couldn't agree more with Dr. Sardi. The era of 3D, one thing I teach my fellows is don't over repair the valve. Because once you get in there, I think you can figure out all sorts of extra pathology and imagine that there's all sorts of extra clefts. There's, you know, maybe the anterior leaflet all of a sudden looks like it's prolapsing. Don't over repair the valve. Look at, really spend time appreciating the mitral valve by TEE. Really, you need to become experts at reading TEEs. The 3D can really help you figure out in your mind exactly what your operation is going to be, just like Dr. Sardi said, and do that. Don't imagine new pathology once you're in on the incision. Robotic incisions tend to heal very nicely. Patients do very well. We've tended to utilize new protocols for our patients in terms of pain control post-surgery. It's the ERAS protocol, or Enhanced Recovery After Cardiac Surgery, the key tenets, and we've got a very drawn out protocol. I'd be happy to share with anybody if they would like to see it. The keys are we let patients stay hydrated. So they drink clear liquids up to 2 hours before surgery. Some protocols even tell patients to drink electrolyte solutions like Gatorade, which we get in the United States, and drink like 2 liters of it the day before surgery. All patients get pre-op acetaminophen as well as Neurontin. Intra-op, at the end, I will inject the intercostal spaces, and I actually do a nerve block utilizing liposomal bupivacaine diluted with saline. And basically I'll locate the rib, march down to the intercostal bundle on the inferior aspect, and just march right off of it, and then give little wheels of this liposomal long-acting bupivacaine, 2 interspaces below the incision, 2 interspaces above. And then I'll put a little bit right in the wound. It really provides about 12 to 18 hours of really comfort for these patients. Post-op, they're given a regimen of 1,000 milligrams of Tylenol PO, IV, and then they're put on a Q6 regimen of PO. We supplement that with Neurontin or gabapentin, which is 300 milligrams, and then IV Toradol for 3 doses. We'll give narcotics as needed. It's pretty rare that we have to give our patients narcotics. They're pretty comfortable. And I discharge them on a combination of acetaminophen, Neurontin, and usually they go home day 3. They often extubated in the operating room. I take out all the lines I don't need, so the PA catheter comes out. They go up with a 1A line. That second arterial line is removed. I will usually keep them in the ICU overnight. Often, if they get out early, we need beds. Sometimes I let them go upstairs by the evening, and that way they're in a quiet room, not in an ICU setting. They spend 3 nights and then they go home. So rapid extubation, discharge post-op for 3. And I tell all my patients with minimal access approaches, either endoscopic port access or the robot, they could resume full activity at 2 weeks. And then I see them annually, just keep an eye on the valves. So I think this could even be utilized for, we've looked at multiple different scenarios in terms of, is minimally invasive safe, or are we pushing the limits too far? We've looked at patients with LV dysfunction, and we've noted, of course, longer operative times, but really minimal conversion to sternotomy. And our conversion to sternotomy rate is about 2%, 2.5%, somewhere in that range. Notice that those patients with an EF of less than 40% had similar outcomes to those patients with an EF greater than 40%. And that includes mortality, wound infection. I'll tell you, these thoracotomy wounds, it's pretty rare. We've never seen a deep wound infection, and really a minuscule rate of superficial wound infections. But really no difference in long-term outcomes. Recently presented our data, which is coming out in the Annals of Thoracic Surgeon, but even in the presence of pulmonary hypertension, we found that you can do these operations safely with good long-term survival. And we've looked at our survival out to 10 years. We've looked at intermediate and high-risk patients. This paper is, I'm on my fellows, but still in process and should be submitted soon. Cost factors, I will say, take this with a grain of salt. This is, of course, looking at the American healthcare system. When we think about cost, there is significant cost associated with our approach. We looked at the cost. We looked at our cost at about $25,000 for the operation. And that does take into account equipment and the endo balloon. So, but what we noticed is that we were able to offset the added cost between our minimally invasive approach with shorter lengths of stay. So we saved on the hospital length of stay. So this paper is really probably more regionally dependent. So take it for what it's worth. So in summary, I think the maintenance of long-term outcomes is absolutely critical to the application of minimally invasive platforms to mitral valve repair. Appropriate screening can help avoid potentially devastating complications. A realistic understanding of one's surgical experience is critical to ensuring success. and a careful, calculated approach to expansion of to mixed to complex mitral valve pathology can allow application to a spectrum of pathology. So I always take the opportunity to, of course, acknowledge my research team, and which allows a lot of the research that I demonstrated to you to be possible. So with that, I would love to.
Thank you. Thanks, Dr. Tluri. Thanks. It's a great disposition of technique and technology for the mitral valve repair. I'm sure that we all are going to get benefit out of your presentation. Let me ask my panel and also Dr. Payman to put some questions to you and also make some relevant comments. Over to the panel, please.
Dr. Pawan, it was an excellent presentation and very inspiring. And I think because in my institution, we have acquired a robot about a year ago, and we might be starting a robotic cardiac surgery program this year. And I think other institutions, Dr. Yugal is already doing a lot of robotic surgery, and other institutions are also doing. And I believe that with your help and other colleagues' helps, India would lead in this frontier also. Thank you.
Oh, thank you. Yeah, no, I think that we're all colleagues in this together, and we need to work across our oceans to make sure that we help each other advance the field. So yeah, there's a lot that I've learned from Dr. Mishra and the rest of you that I use in my daily skills as well. So this is a fantastic. Across the Atlantic, the two giants are in this platform. And what I see that now in North America, a lot of centers are now trying to establish a robotic platform for the mitral valve repair. While in the Western Europe, there is some reluctance, though they started early on. I remember I visited in 2001 and 2 when we were starting a robotic program, a couple of centers. I was in Arles, though they were not doing it, Venerman was the one who was utilizing the same, the endoclamp. Now somehow I have seen Doug Murphy, the one who is doing that. Dr. Pawan is doing that. We started with, 98, 99 with endoclamp. And of course, the NYU team helps us. Gene Grassi came and they helped us. Yeah. But somehow, eventually, because the cost at that time, we were having issue with affordability. We had a pact with 50 kids, the part of training to go to, Salt Lake City, where there were, the animal lab and the center where they were training us. But eventually there's, the availability issue, though I wish to use, the endoclamp in a robotic setting and also redo situation, which you have said. But unfortunately, there were a couple of handshake from, the hard port to going to Edward, J&J. I don't know, now Edward is home. And still we do get a problem with, the cannulas and endo. And in Europe, I think, I don't know how many centers are, Dr. Payman can tell you, not too many centers even in Europe, considering the cost. In North America, I can put into tips that these are the centers which I have visited, I've seen that. So I don't know what the Lolme is, the Gene Grassi is using this in NYU, I don't know. But definitely. Yeah, Gene and Didier are. I will tell you that I've got sort of mixed feelings on the whole thing. We just started reusing the endo balloon probably about 6 months ago. There was about a year and a half when it was off the market. And, I can probably give you a 1-hour lecture on just the endo balloon itself. Because there's also, I showed you the learning curve. I mean, when you get the complications, it's not, they're complications. They're not pretty. I've had colleagues that have tried using it without experience. They've destroyed aortic valves. They've had the balloon end up inside the heart. You can cause damage with the endo balloon. So I do want to provide the word of caution on the endo balloon. There is a learning curve. I think it's important that we learn from each other on how to use it. the latest recall on that balloon was the balloons were rupturing because they had manufacturing issues. So I had probably 4 patients over the course of a year where, you know, you're sewing, you're working, next thing you know, you get all this blood in your face and the balloon's ruptured. And, you know, it wasn't the needle that went through it or anything, because I wasn't up near the trigone. And so then you end up having to deal with those. So the balloon is not for your problem. I will say those things being considered, I found with a robot, it makes a big difference because you don't have that, the chitwood clamp by the left arm. With port access, I mean, it's nice. It's not critical. The advantage is, Dr. Sardi probably will agree with this. The advantage is at the end, you know, and I always find the most painful part when I use a chitwood clamp is dealing with the site. Usually it's okay, but every once in a while when it bleeds a little bit and you're putting stitches in and you're trying to get it to stop, it can be a little painful. So you totally avoid that problem with it. But you do have to remember, and I want to be very careful in how I convey the message, that there is a learning curve with the endo balloon. If you're not careful, and the other critical piece is the perfusionist. I've got 3 perfusionists that I work with for the endo balloon, because they are constantly managing the pressure inside the balloon. It's very different from a perfusion standpoint, and there's a lot more to be dealt with. So it will take an even more specialized team if you're working with the endo balloon.
So, you know, in my experience, I just quote two instances. One, when we were using the Edward one, and when I was taking the annular suture towards the aortic valve, I ruptured the one. And then now I'll tell you, there was another competitor, the company Estec. They came out with a balloon which was mounted in the cannula itself. So we were doing a robotic TCAPs, heart was arrested, and somehow that balloon ruptured. So we have to complete the job on fibrillating heart. This I'm talking in 2004, 2003. You know, so Estec anyway is out. Here at least you have a endo balloon which you can take out and redeploy another one. With the Estec cannula, if you know, I don't know whether you have seen or not, there's a long cannula, and the balloon is mounted in the end of that Estec aortic cannula. I mean femoral arterial cannula. So those were the time. Now the Edward balloon is much better. You know, the material is good and
it's better. They've re-engineered it. So, right. But there's still issues with it. It's not perfect, right? But it's pretty good. I will say I'm an advocate of it. I'm a proponent of it, but with caution in terms of young surgeons. I was fortunate that my senior mentor, Clark Hargrove, had done several hundred of those. And so I learned from his learning curve and didn't have to make the same mistakes. So I think it's important that you pick up all the tips that go with it.
Dr. Payman, please.
So thank you for the excellent talk. So I just wanted to interject in the discussion with regard to the endo balloon. So I think you have to consider interclude or endo balloon as an operation on itself. So at this moment, I mean, what I do is interclude endo balloon. If there is any anatomical issues, I do the chitwood, and in some cases I use the fibrillating heart. So really based on the patient's anatomy and condition. But the reason that you need to be cautious, and I always say in the beginning, you have to start with the chitwood, you have managed the operation, you have control over your team, and then you introduce the balloon, and you will have a lot of pleasure of introducing the balloon. The reason is the interclude or endo balloon is a dynamic occlusion. It is not like a chitwood, you put a clamp and you don't even need to think about it anymore. Interclude is a dynamic occlusion because if you give cardioplegia, because of the pressure goes high, the balloon can move. If the systemic pressure goes up, the balloon can move. So there are many things that you have to consider, and if you understand the balloon and you have control over your team and you have control over the approach that you're doing, then it is easy to manage, and it is a great tool. But I think in the starting the procedure is you need to be cautious. You start with the Chitwood. The most value of the balloon is for reoperative, of course, surgery. But I mean, it doesn't make any sense to use it only in reoperation, because you never will build up your experience with it. So, so my point is, first learn the procedure, have the control of it, do a couple of hundreds, and then you can introduce the balloon.
And I think the other point, that's an excellent point, and I think we're both in total agreement on that. The other point that parallels that is, when you start this operation, start with a small team. I think many of us have many anesthesiologists, perfusionists, nurses. Pick your 1 or 2 scrub nurses, pick your 1 or 2 anesthesiologists, pick your 1 or 2 perfusionists. Do your first 30 operations that way. If you're starting a minimally invasive program, don't introduce too many variables into it. It'll just cause too much confusion.
Yeah, exactly, because that was also the point I wanted to make. You have to have dedication, a dedicated team for mitral pathology in general, and that is crucial. And I think you have to empower your team also, because it is all about ownership. You want people around you having ownership regarding the program, what you're doing, as you have over the operation. So I think the way of success is to be able to create ownership among your team members, and then at the same time, the success when you have the ability to delegate to your team members the things that they are best at. So, for example, for the cannulation of the SVC, what I do, I ask the anesthesiologist to put the sheet. They are excellent at putting sheets. So they put the sheet, I drape the patient, and I cannulate over the sheet under TE. Why I do that? Because they are best at putting the sheet without thinking about it, but I have extra control, because you have so many complications that could be associated with SVC cannula. So you have to think about all the steps of the operation, all the steps, and have a small team, especially in the beginning.
Great, great. So
I have a question.
Yeah, yes, please.
Yeah,
please.
Dr. Pawan, it was an excellent talk. Why do you have a bicable cannulation compared to a 2-stage venous cannulation? That is one. Second, what is the reason for blocks, complete heart block, and when you use a complete ring? Any particular reason how to avoid?
Yeah, so I think the first point, if you ever end up with not enough drainage on a minimally invasive approach, you will notice how painful that operation can be, because you get tunnel vision.
Agree.
And so we've just gone to, yes, can you get away with a dual stage cannula? You place the femoral cannula, you just put it up into the SVC. Yes. Don't forget, once you pull up on your retractor, you're also taking the cannula, and the cannula will be moved. It's dynamic, and you may lose some of that drainage.
Okay.
But when those situations, I'd rather have extra drainage than not have the extra drainage. And those situations where you don't have good drainage, there's nothing more painful than having the right heart full. So that's why we do it. In bigger patients, you'll see that you'll need it, but in all patients, it provides a benefit. I don't see a downside to it. But I know there's others that do it with, like the S-Tech, I think makes a good dual stage cannula that people use. But there's other opportunities. It's just my own practice. I've found that it doesn't add that much to getting the patient to the operation. My anesthesia team, I felt very comfortable with them getting that line in, and so I've enjoyed having the extra drainage. In terms of the pacemaker, that's something that we're thinking about and looking at more. I think the issue is more with those additive stitches that you're placing near A3, to the lateral aspect along the anterior part of the annulus once you come around after the trigonal stitch. I think those few stitches, and the more stitches you place, the closer you get to the AV node is the best I can gather. In terms of the pacemaker
For
rates.
the venous cannula, you use a arterial cannula or a venous cannula?
Say that again?
Do you use arterial cannula or a venous cannula?
I use
For the SVZ, do you use the arterial?
I use the Edwards femoral arterial, the wire wrap, the one with the narrow tip on it. That's the one I use.
I just want to make a comment with regard to the cannulation. One of the most prevalent pitfalls in minimally invasive surgery is related to fundamentals, cardioprotection, doing an operation in a safe way. The most of the disasters happen in that field. The cardioprotection is not only giving cardioplegia, but having the heart empty, having a good exposure, being able to do an operation much quicker when you don't have a good exposure. So it is also about reproducibility. So you can do one cannula and probably it will work in patients who are small, less than 80 kilograms maybe. But having two cannulas, you have actually reproducibility in a sense, having good drainage, protecting the heart. And the other thing is, remember, having a peripheral cannulation and peripheral perfusion, even with one cannula, you have to go and talk to your perfusionists. You see that they have to lower the flow sometimes most of the time. So your flow during the operation fluctuates. So you don't have, for example, a patient needs a 4-liter flow, but if you look at what happens during the operation, they give maybe 3, and then it fluctuates 1.5 liter during the operation to be able to accommodate the surgeons. So having 2 cannula provides you also with a stable perfusion, and a stable perfusion also is much protective for everything. So I think I have done, I've tried all of those cannulation, 2 cannula with closing cava, with active drainage, with the vacuum assistant. I think the vacuum assisted with 2 cannula is the best way. The most ideal way is, of course, if you close the cava in all cases, but I mean that gives you an extra step that you only need to in tricuspid.
Great. So if there are no more questions, let me thank both of you, Dr. Payman and Dr. Atluri, on behalf of society and on behalf of scientific committee of these programs. And I'm sure that in future we are going to interact much more, and of course pass on the knowledge, techniques, technology to next generation, where we are now thinking in that direction. So thank you. Thanks for your time. And let's bind up the time. So thank you.
Thank you, Dr. Yugal, for organizing such a wonderful program. And I think the programs like these will go a long way in bringing the cardiac surgery to its glory in this country, because you are aware that how we are faring in the terms of glory of cardiac surgery to the young trainees in this country. So I think these programs are going to bring that glory back.
Thank you. Thanks.
Thank you.
Thank you.
Thank you, sir.
Thank you, everybody.
Bye.
Thank you.
Bye, sir.
Thank you. Have a wonderful day.
Thanks.